Yeah, for this very nice talk and impressive case. Questions to all three. So before you can have your lunch, any triggering questions here for monitoring, imaging, biomarkers, ultrasound, MRI, others?
May I? Yeah. First, for Jordi, do you really need MRI for diagnosis of Pompe disease?
Not now.
Okay.
So not now, because now with the panel of genes, at least
Sure,
in
yeah.
the countries that have access to panel of genes, please
Yeah,
bear that into account, because there are many countries where panels of genes is not a reality. But in panels of genes is very rare. There is a doubt with the panel, you can do an MRI and see if this is compatible, but of course there are other ways of measuring GA activity.
So I assumed it was an old slide.
Yes, but valuable.
Now, another question for Neha. First of all, thank you very much. It's all very interesting, and I think I like when something new is presented by young people. This is really wonderful. Couple of questions. First, about ultrasound. Do you see any signs of inflammation? Because ultrasound is used for inflammatory myopathy, inclusion body myositis. Do you really see any signs of inflammation? Because in the biomarker, it shows up every time that there is a sign of explanation. And about your last patient, I think it's a very unusual case.
Yes.
Very unusual case.
Yes, yes.
And and I have some questions about it.
Sure. So, Dr. Nina, so the thing is, the utility of quantitative muscle ultrasound was indeed started with the research involving around the inflammatory myopathies like polymyositis and dermatomyositis, etc. That is how we try to incorporate that same findings into utilizing whether or not it would be applicable for Pompe disease patient or not. However, the downside is, although we do see the echo intensity that increases, we are still not sure whether it is the glycogen deposition or it's the fibrosis that's undergoing because of that increased echo intensity that we measure.
For sure, it is not fibrosis.
Yeah, so it is more or less either a either a fat replacement or the.
It is not fat. So you cannot have a signal that reduces over time, and it's fat or fibrosis, because when there is fat, there is no comeback.
Yeah.
So fat and fibrosis replacing the muscle, it's not going to improve with the treatment. So you cannot see a signal that goes up and down, and that reduces with the treatment, and you think that that's fat or fibrosis. That's impossible.
So
that should be something, I don't know what it is.
So
but
yes,
it's
we are.
Something that can change with the treatment. I don't think you see glycogen with echo.
Okay, that's an excellent point. Thank you, doctor. But we are still confusing because is it a glycogen accumulation that we are seeing, or it is something else that's happening? So we cannot actually precisely quantify whether or not it is the inflammatory changes that we are picking out on muscle ultrasound.
In a way, you can respond, or you can give the answer to this. Sorry, you can give the answer to this by the C13 imaging he's done. The peak of glycogen is so small that never it would transfer in an ultrasound signal. Yeah. So you need sugar completely stuck in the muscle then to show this. Therefore, this is definitely not sugar what you can pick up with ultrasound.
And it is surprising, so that's my question for you. So how do you explain that the muscle where you see more changes, which is the quadriceps, is the muscle that is the last one to be affected in MRI with fat, and the muscle that is usually from a clinical point of view, late onset Pompe patients, that they don't have any issue with the quadriceps until late in the disease of the progress, and late in the progression of the disease. How do you explain that?
So the thing is, as I just talked about, these are asymptomatic patients. They do not have any clinical symptoms. So definitely they do not have this progression of muscle involvement. This is the very early catch that we are doing in these infants who we have found these muscle ultrasound related changes. So it is not definitely the end stage muscle pathology that we are picking up. These are the very subtle early stages changes. And that is why it was remarkable for us to actually find the increased echo intensity in these patients who are essentially asymptomatic. They are running, they are more or less like normal kids, and but then still they had these subtle changes that could be picked via the quantitative muscle ultrasound. So I think it is still the early phase disease that we are capturing.
Just a quick question about the muscle ultrasound. So is that a commercially available technology? I can go into my doctor, ask her to prescribe one for me, or do you have to be in like a clinical trial, something like that?
Thank you for this question. Actually, the utility of this muscle ultrasound is it should not be research study bound. By that, I mean that we can actually generalize this practice, and it can be readily be done by any neuromuscular specialist or a neurologist or even a physical therapist who has a training in muscle ultrasound, and they could pick up these findings.
Hi, I'm Andrea Alberschik from Regeneron. My questions are for Dr. Diaz and Dr. Regmi. First, would you recommend muscle biopsies, for example, in clinical trials or clinical practice in posterior thigh muscles or like another region? And the second question is muscle ultrasound and imaging. What's the underlying process for seeing the muscle thickness increase? And I guess the related question is, what's underlying muscle atrophy? And it seems that the ultrasound signal, you're unsure right now. Thank you.
So regarding the muscle biopsy, I think it depends on what you want to study. So if you want to study glycogen content, by today, I don't think that we have a tool that is non-invasive that can answer that question. I still think that there is a lot of research to be done.
So what I'm actually asking is, doing muscle biopsies for glycogen quantification hasn't panned out for clinical trials. Like the results haven't been conclusive. So I'm just wondering if that's because we're taking biopsies from the wrong muscles.
Oh, I don't know. I think it's too early to answer that question. What we have seen is that it could be. But I don't know. There are differences in glycogen concentration between different muscles. And then another important point that I have not mentioned is the relation with the feeding. So we did all these studies in patients that had not had any meal in the last 12 hours before the MRI, which is important because MRI can also identify changes with the glycogen related with the fact that the patients have taken some food. This is also important for biopsies as well. So that's something that to take into account.
Thank you. Sorry, Giancarlo. I also have a question for the imaging persons. My name is Nadine van der Beek from Rotterdam, from the Netherlands. A question for both of you. Have you correlated your MRI with the echo findings? So that's one question. Another question is, you do the echogenicity of the muscle. Do you anything about the echogenicity of muscle in normal evolving children? Have you done that? Because I can imagine that might probably also change when they grow. Yes. And I have a comment. That is, please do also not forget one of the most important muscles in Pompe's disease, which is the diaphragm. So, and you can also beautifully image that. So, those are my questions.
So, thank you so much for this comment, because first and foremost, as if you all had noticed while describing about the measurable factors for quantitative muscle ultrasound, for muscle thickness, I specifically mentioned that it is a crude assessment tool. First and foremost, the reason behind that is these children are growing, they are developing. So with this developmental progress, there will be increase in muscle thickness. The bulk increases as they grow in their height, in their weight. So we cannot typically arrive into a conclusion just based on the muscle thickness. Because of that reason, on our correlation analysis, we did not consider the muscle thickness to be an important conclusion. Rather than that, we actually try to correlate this muscle thickness measure with the functional assessment tool, just to see whether or not it could correlate nicely or not. And second, for asymptomatic patients, so that was the main highlight of my topic, because these newborn identified via newborn screening were not at all symptomatic at the time of presentation, but these muscle-related findings were picked up on the longitudinal assessment. So I think that we can actually incorporate that. However, we are on a very earliest phase of studying and identifying these changes, and there is a need to have much more research study to actually see that what this increase in echo intensity is and how it can actually help us to derive a normative or a reference data that we can actually compare it to.
And then I would like to add something. Just, I don't think that the question is to decide if we do echo or ultrasound or we do MRI. We can use both things, so we can complement both techniques. That's something that is doable. We haven't correlated the results, so I have no experience with ultrasound myself, and we haven't done it. But there are two things that I want to also raise here, because I think it is important. I have nothing against ultrasound, first. That's my disclaimer. But when you see a slide where it says MRI is very expensive, MRI it's between 300 and 500 pounds. And we are talking here about treating patients with a treatment that costs hundreds of thousands per year. So are we really talking about 500 pounds for deciding if we start the treatment, yes or no? That's the first thing. Second thing, it's a lengthy process. How much time do you need to look at all these muscles with the ultrasound? It's not a 5-minute thing. So with 20 minutes, I can scan a patient with a whole body Dixon, and with 20 minutes more, we have the carbon spectroscopy. So it is true that it is difficult for babies, without no doubt. It is true that it's difficult for patients that have respiratory involvement, even though we have done MRI to patients that are ventilated. And for me, it's a complementary test. There are muscles that you can really study very easily with ultrasound, facial muscle, abdominal muscles. And it can be done to babies, but with the MRI, you have lots of sequences that you can study different things. So it's a complementary test.
Oh, can I ask? Yeah. Can I have a few questions. We're gonna have to fight it out. Okay. So the first one is on the ultrasound. Just wondering for, I think it was Neha. There is a company called Muscle Sound, and they're based in Colorado. They claim to be able to detect glycogen with MRI, or not MRI, ultrasound. So I think also they said it was based on echo intensity, and it actually correlated pretty well with muscle biopsy. But there was some question. You have to get the precise location in the muscle for it to correlate, because the glycogen can vary quite a lot within a single muscle group. So I'm just curious if you've heard of that company. I tried to get my doctor interested. We actually had a meeting with the CEO, and my doctor was kind of skeptical that it could actually detect glycogen.
Yeah, so this is the very first time actually that I have heard of something like this. Looks super interesting, but I need to find out more about what their procedure is, like what system they are using, and like is there any modification in their system or setting that could develop, like that could actually help us see the glycogen. I have not, honestly, I have not heard about it, but I'm interested to know more, so maybe we can just talk about it after this, and maybe we can, if it's helpful, I think it will be really helpful for the Pompe patients.
Right. And then for the muscle MRI. I guess in Pompeii, wasn't known for being a disease where there's a lot of muscle cell death, like in Duchenne. Are we certain that it's actually cells being replaced by fat? Could it be fat deposition for some other reason? I'm just curious, how does the fatty replacement compare, like on a per year basis, to Duchenne?
But that's completely different diseases, as you are already mentioned. So in Duchenne, you have a strong necrotic process going on, and this is much quicker than late onset Pompe disease. But in Pompe, there is for sure muscle fibers that are lost and replaced by fat. So when you look at the muscles and that have a strong fat replacement, which is not very frequent because in general we do muscle biopsies of the quadriceps or the biceps, which are muscles that are not strongly replaced by fat. But if you do a biopsy of one of these muscles that are replaced by fat, you can see that there is a massive loss of fibers that are replaced by fat. So yes, I'm convinced that this loss of fibers that is associated with expansion of fat tissue. And then in regards to your first comment, so glycogen content is becoming very trendy. But please bear in mind that we don't know if glycogen in the late onset is predicting anything. So we don't know if its glycogen increase what is going to trigger symptoms or what is going to produce to lead to a worsening of the muscle function. This is something that is not established yet. So it's a biomarker that is interesting. We have treatment that try to reduce glycogen, so it can be useful to see if the treatment works from a biochemical point of view. But is there a correlation between glycogen and muscle function? Is glycogen predicting changes in muscle function in late onset Pompe patients? I think that we are very far away of knowing that.